I'm going to be speaking a bit about healthcare, and I wanted to start by saying that it's a huge pleasure to be here, an honor to be here, and I want to thank Drummond and Ellen for getting me here, and Rachel Johnson for putting 3 or 4 different versions of my PowerPoint slides up in the time before my talk. I'm told that I have about 18 minutes to speak, and that's pretty good. It reminds me of one of the first evaluations I received as a new assistant professor at Yale. It started very promising. It said, "Professor Hacker, if I had just 15 minutes to live, I'd want to spend it in your class." Yeah, because that way it would seem like an hour. Okay, so I will try to make the next 18 minutes seem like 18 minutes, and since I'm going to be talking about a subject that's pretty complex, I thought I would start not with some statistics, but with a story. And the story is embodied in this picture. If you see here, you see a typical American family of 5. You have Arnold Dorset on the left. He's an air conditioner repairman. He makes good money compared with what his father made. He makes about $70,000 a year fixing air conditioners. He makes that $70,000 a year, it turns out, because he's working 90-hour weeks. And the reason that he's working 90-hour weeks, and the reason that his wife, Sharon, on the right here, is staying home to care for their kids rather than finishing her nursing degree, is that it turns out that their son, Zachary, with the football shirt on, has a rare immune system disorder. You see, by the time that Zachary's disorder was diagnosed, the family had already run up $30,000 in credit card bills to pay for his care. They couldn't make their car payments, they couldn't make their mortgage payments, and they were about to lose their house. And so in 2005, when this picture was taken, they decided to succumb to the inevitable, and they filed for bankruptcy. In that year, they were one of 2 million American households that filed for bankruptcy. 2 million. And this is what Arnold Dorset said about filing for bankruptcy. He said, "I make good money, and I work hard for it. When I filed for bankruptcy, I felt that I had failed." Arnold Dorset felt that he had failed. But of course, his story is a story that's told again and again in the United States today. Of that 2 million number I gave you before, we're probably talking about half, 1 million households, are filing for bankruptcy in part because of medical costs and crises. That means that roughly every 30 seconds, someone files for bankruptcy in the United States because they can't pay for medical care. And of course, they had health insurance, or rather, they had health insurance. And this is the thing that we often forget. Recent years, we've seen more and more evidence that those who have health insurance are often ill-protected. For example, Consumer Reports just did a survey. They looked at the underinsured, and they found that 3 in 10 non-elderly adults who were insured were not adequately protected against medical costs. And those who are not adequately protected against medical costs end up doing the kinds of things that those who don't have health insurance at all do. They put off care, they put off other essential expenses, as the Dorsets did. They dig into their savings for retirement or for a rainy day. They make job-related decisions based on health care. And here's, I think, the really striking fact. If you look at the characteristics of this group, the underinsured, they look just like those who have health insurance. They're just as likely to be white, they're just as likely to work for a large employer, and their median income is exactly the median income of the insured. Put another way, these are people just like us, only they're at grave financial risk. And this problem is growing much, much worse. Just the other day, the Commonwealth Fund, a New York-based research organization, released the results of its health insurance survey. And what they found is that between 2003 and 2007, that's 4 years, the number of Americans who were uninsured during the year or underinsured according to their classification of the underinsured had risen from just over 60 million to 75 million. That's a 60% increase in the underinsured in just 4 years. So we are heading more and more towards a system in which even people who have health insurance aren't able to pay for the care that they need, or find that they're not able to pay for that care when they get sick. And the scary thing is that they are the lucky ones, in the sense that those who are uninsured are at much greater financial risk. You've probably heard that there's about 47 to 50 million Americans who are uninsured. But I think the number that you should keep in your mind is 1 in 3. 1 in 3 non-elderly Americans go without health insurance every 2 years. That's about 80 million Americans, and the majority of them go without health insurance for more than 9 months. And those people aren't just at risk in terms of their financial well-being, they're at risk in terms of their health care. In 2002, the Institute of Medicine estimated that about 18,000 people a year die, working-age people die, because of the lack of universal health insurance in the United States. Just recently, the Urban Institute updated that to 22,000. But that's not really the scary statistic. The scary statistic is that among 19 rich nations for which we have this evidence, the United States ranks last in preventing preventable deaths before age 75. It's called amenable mortality, and we're at the very bottom of the rankings among all these nations, 19th out of 19. That's actually a little bit of a fall from 5 years ago when we were 17th out of 19. At 19th, we are well underperforming other nations, even though we spend vastly more for health care. Just to give you a sense of what this means, if we had the average rate of amenable mortality, preventable death before age 75, of the top 3 nations, we would have 101,000 fewer deaths a year in the United States. 101,000. I just moved from New Haven to Berkeley. I came over on a 757, seats about 100 people. So 1,000 757s would have to fall out of the sky in a single year to be the same number of people who die in the United States because our healthcare system is so poorly functioning. So these kind of numbers provoke despair. They provoke despair in part because it's unclear what we can do. We have a system that is heavily reliant on employers to provide a basic foundation of security. And what are employers doing? Well, the story is pretty well summed up by this figure, which comes to us from the Economic Policy Institute. The proportion of people who get health insurance from their own employer has declined by 15 percentage points. And this is obviously an understatement of the problem because it doesn't include, for example, retiree health benefits, which have declined from virtually 100% of workers in many industries getting benefits to, we're moving toward a world in which almost no one is going to get retiree health benefits, and they're going to be fully reliant on Medicare. Now, you might think this is just because people who are less educated aren't getting health coverage today, but you would be wrong, because in fact, there's also been a very steep decline in health insurance among people who have a college degree. For example, at the most recent survey time, 40% of recent college graduates entered their first job without health insurance. 40% of people who had a college degree. So we're really talking about an implosion of the employment-based system that we once relied on. But what could take its place? And that's what I want to talk about today. Because of course, when you look at these kind of figures, you think we just have to fundamentally reshape the system. We need something totally different. For example, we need a universal national Medicare for all plan, something that I think would be a vast improvement over what we have today. And then we think about the politics of the issue. I mean, look at what's happening right now. We've got conservatives trotting out horror stories, talking about socialized medicine. They call Medicaid and S-chip socialized medicine. You've got John McCain saying, yeah, we should change the system. Let's move everyone out of employment-based health insurance so they can buy health insurance on their own. And let's promote health savings accounts so people aren't bearing enough risk today. They need to have more skin in the game. Yeah, I'll tell you about skin in the game. Here's a guy who had some skin in the game. Yeah, he looks pretty ominous, doesn't he? His name's Felix Meshke, and that's his son on the left. Felix Meshke decided that health savings accounts might be a good idea, so he signed up his family for one. And a few weeks later, he found himself in the hospital deciding whether to put his son in the hospital overnight. And he decided to do it, and they got hit with a huge bill that would have been completely covered under their old health insurance plan. And here's what Felix Meshke said. He said, I felt that I had neither the bargaining power nor the mental capacity. When you're bargaining for a car, you can always say, I'll walk off the lot. But when your 1-year-old child has an IV in his arm, you don't have that same option. And here's the thing. Felix Meshke is a professor of finance and management. at the University of Minnesota. If he feels that he can't bear this risk, how do you think the rest of us will feel? So we need reform that brings us back into a common pool of shared risk. And yet we know that this will be a difficult task. One political advisor, famous political advisor, summed it up pretty well. He said, "There's nothing more difficult to accomplish nor more dubious of success than to initiate a new order of things. The old system has defenders that are strong, while the new system has only lukewarm support from those who would benefit from it." That well-known political advisor was Machiavelli. So we have an embedded system on which millions of Americans rely, and we know that critics of reform are going to trot out horror stories to scare those who are reasonably happy with their private health insurance today. I can tell them, you can tell them, that they shouldn't be. They should be frightened, because the future looks like what Felix Meschke experienced, or like what the Dorsets experienced. But the truth is that it's going to be a very hard fight. And so I've spent the last 5 years or so working to develop a proposal that tries to get around this embedded system, both thinking about the politics of reform and thinking about how can we achieve a system that has the essential goal of health security for all Americans. We don't want some minimal system that requires that people get poor private insurance. But can we get a system that will provide health security to all Americans and yet might also be politically realistic? And that's what I've been trying to do. And I'm happy that those efforts have begun to bear fruit in the sense that some of the work I've done has seeped into the work of the presidential candidates on the Democratic side. And I'll tell you a little bit more about some of the coalition building work that has been taking place around this broad idea. So the essential elements of my plan are pretty simple. It's called Health Care for America, and you can find it on the website of the Economic Policy Institute. They have a project called the Agenda for Shared Prosperity. Basically, it has just 3 elements. It would create a new framework for receiving health insurance for those who didn't get health insurance from their employer. It's called the Health Care for America plan. And that plan would look a lot like Medicare in the sense that you could get a public insurance plan or you could buy a good private alternative, one that I'll emphasize would have to compete on a level playing field with the public insurance plan. At the same time, employers would be required to offer good private coverage or to pay a pretty modest amount, 6% of payroll, to fund coverage for their workers. And finally, I would include a requirement on individuals to get coverage on their own if they didn't get coverage through their employer. But most Americans, about 94% of the non-elderly population, would get coverage automatically through their place of work under this plan. Now, what would be the effect of this plan? Well, I'm very happy to report that according to estimates that were done by the Lewin Group, it was implemented last year, and so I can tell you. The first thing to say is that our current system is woefully inadequate. While 61% of non-elderly Americans get coverage through their employer, about 20% are uninsured. And we have a system, Medicaid and S-CHIP, that fills in this gap and has been growing in size, but is underfinanced and in political peril in many places. Under the Health Care for America plan, we would move to a much more stable foundation. Basically, large employers that already provide good benefits would probably continue to do so. About half of coverage would come through that source. The other half would come through the new Health Care for America plan. In my proposal, at least, Medicaid and the state children's health insurance program would be folded into this new national pool. However, people would get wraparound coverage that would make sure that the coverage they received was as good as what they had before. A couple things to note. The benefits here are very comprehensive: mental, maternal, child health, no cost sharing for preventive care, well-child screenings, and so on. Prescription drug coverage with the government able to bargain on your behalf for lower prices, and importantly, for anyone below 200% of the poverty level, no premium whatsoever, nothing. The maximum premium, yeah, that sounds pretty good. The maximum premium for people who have incomes that are pretty high would be, and this is pretty good too, $70 for a month for an individual and $200 a month for a family. Now, this is just sounding so impossible, right? So I need to tell you about the other side of the proposal. Well, how do I pay for it? How would it control costs? And here the answer is also relatively simple. Because what it does is it builds on the ability of the government to be able to get both lower prices and to get much, much better administrative savings, much better administrative cost. So in the first year, this is just the first year, it would cover everyone, and we wouldn't spend another dime on health care relative to what we would have spent. In fact, we spent $100 million less. So we're getting everyone covered, and this does cover people who are working but who do not have documentation as long as they are in the workplace. And we get everyone covered, and we don't spend anything more. And you can see that a big part of the reason for that is that the administrative savings are huge, right? About $30 billion. All those small private plans that are operated by small employers, for the most part, would be replaced by this broad pool. And moreover, this plan would make the self-employed come into this large pool and pay a very reasonable amount for their coverage. So again, lots of fragmented individual and small plans would be we'd be moving from that towards a more universal system. Now, there's a one-time savings, and you can see that you get enough savings in one time to be able to cover everyone. But then there's the question of, well, how do you save money over time? And most people kind of throw up their hands or talk sort of vaguely about comparative effectiveness as if we have no evidence about how this can be done. Well, we actually do. It's called the rest of the world. Okay, mid-1980s. Until then, our spending looks just like the rest of the rich world. Suddenly, you can see that the U.S. spending continues to rise. U.S. spending, if we had risen at the average rate for other rich democracies, would have been here. This is 11% of GDP versus, in 2002, almost 14%. The difference here is $440 billion. That's more than what we spent in those years for both Medicare and Medicaid at the federal level. So we're talking about very substantial savings. Indeed, the Lewin Group estimated that my proposal would save $1 trillion over 10 years in national health spending. The other side of it is you might say, well, other countries can do it, but how do we know that we can? Well, there's a pretty simple answer, and it's called Medicare. Now, again, we hear all about how Medicare is going broke, we can't afford it, it's running out of money, and we never hear this simple fact, which is that if you look since the 1970s, the lines have crossed in terms of spending in excess of the overall growth of the overall economy. This is our spending on elderly Medicare beneficiaries. This is our spending on the rest of the population through private insurance. Notice something about these two lines. One goes down, one goes up. The Medicare system has been doing better and better relative to private insurance. How often do we hear about that? So what I did is just said, what if this new pool that would have a much larger share of the population, what if it just kept the rate of increase of cost to the rate of increase of Medicare costs? Well, we get that $1 trillion in saving. We also get something else, which is assuming that employers don't step up to the plate and start saving money on the same scale, because after all, they have to provide good coverage or they enroll their workers in this new plan. What would happen? Well, what would happen over time, according to the Lewin Group, is more and more Americans would be in this new pool. So someone once said to me, this is a Trojan horse for single payer. And I said, well, it's not a Trojan horse, right? It's just right there. I'm telling you, we're going to get there. Over time, slowly, but we'll move away from reliance on employment-based health insurance, as we should, but we'll do it in a way that we're not going to frighten people into thinking they're going to lose their private insurance. We're going to give them a choice of public and private insurance when they're in the pool, and we're going to let them keep their private employment-based insurance if their employer continues to provide it. One other thing is that because we keep the employers in the game, at least for a while, the financing of this system turns out to be relatively easy. Relatively easy in healthcare means it's not trillions of dollars. Let me give you the numbers, because they surprised even me. Here we have total change in federal spending, $49.3 billion. That is the new federal spending that would be required to fund universal coverage, health security for all Americans. Sounds like a pretty good deal to me, $50 billion. Let's think, what is $50 billion? Oh, I know it's $50 billion. The Medicare drug benefit, I know it's $50 billion. The tax cuts for the richest of Americans. And I know it's $50 billion, it's 1/4 of what we spend on tax breaks for health insurance today, most of which goes to those at the top. So $50 billion is a pretty good deal for coverage for all Americans. Well, that sounds so logical. I'm sure that it's going to happen as soon as I can just get someone in Washington to listen to me. But of course, we know the fight's going to be long, hard, and difficult. And so I want to tell you about a coalition that's being created, the Healthcare for America Now coalition. Now, it is actually totally coincidental that my proposal's name and this coalition are the same, although I'm involved with the effort. It turned out that when the Herndon Group, with whom we've been working, looked at the public opinion polling, they found that this broad term, Healthcare for America, really summed up what America's wanted. And indeed, Americans are very, very concerned about their economic security. This is so obvious, it doesn't bear much emphasis. But the fact is we're in a very different place than we were even in the early 1990s. There's a sense of deep pessimism about the future, not just of healthcare, but of economic security in general. And Americans are also highly supportive of having the federal government play a role in expanding coverage, at least in the abstract. When you ask beneath the surface, they tend to split fairly evenly among competing approaches. And the two approaches that seem to be highest for them are no, not health savings accounts. They really don't like those. Medicare for all on the one hand, or relying on employment, requiring employers to provide health insurance on the other. So in a sense, right, I've said, as Winnie the Pooh said when asked whether he wanted honey or condensed milk, yes, right? Let's give them both a broad Medicare system, and let's give them employment-based coverage if they want to have it. But let's make sure that employers contribute to the system, and that employers have to provide coverage. So with the Herndon Alliance's thinking, with some of the broad principles that are embodied in my proposal, the Healthcare for America Now coalition has started with $40 million in money to spend on advertising to make the case for change. Our first priority is to show that we cannot rely on private insurance to deal with this problem, that private insurance will fail us. We cannot just mandate that people get it. We have to have a public insurance plan competing alongside private plans. And so we're going to make that case, and we have a very good spokesman. Last night I got the pleasure to see John Edwards. Well, his wife, Elizabeth Edwards, has been our key spokesperson, and she's an excellent spokesperson. She made quite a stir. I thought she really hit the nail on the head when she said that both John McCain and her would not be covered by Senator McCain's health proposal. I thought that, because, after all, they have a pre-existing condition, and I would guess, if you think about it, how many of us would not be covered under any proposal that allowed insurers to decide who gets coverage and who does not. So, Healthcare for America Now is out there, and it's pressing for a broad approach. It's not trying to detail the legislative specifics. Rather, it's trying to make the case for change, because this has to be a broad movement that brings all of us in. And I was really reminded of that when, after I wrote a piece for the LA Times op-ed page, I got this note. And I get notes sometimes, but usually they're from other people kind of like me. That is, health policy experts, academics. And this was from someone who said, I've never written an author. I Googled your name, and I just wanted to tell you that I think you've got it completely right. Corporations and the government are not looking out for our interests. And then she said this, which I thought really summed it up best. She said, I'm sick of working for the economy. I want an economy that works for me. And it's not a very profound idea. It's pretty simple. An economy that works for people like the Dorsets, an economy that works for Felix Meshke, an economy that works for all of us, because ultimately we are all in this together. So thank you very much.